want to welcome all who have joined today's inaugural DaVita Home for Fall webinar series. I am Mark Schreiber, Chief Medical Officer for Home Modalities at DaVita, and I'm super excited to be with you tonight. Of the Home for the Fall webinar connections with all of you is to really expand your knowledge in issues we believe are both critical and timely both during COVID and as we exit COVID in the next months to come. This series will occur every other Wednesday, so the session will be June 24th at 6 p.m. Eastern Standard Time or 4 p.m. Mountain Time. I will share the planned future sessions at the close of today's discussion. We are seeing more and more applications of telehealth in the medical community that many of us believe will continue as we exit COVID. For your office practice and the home programs, they change the way we care for patients. And it's with that in mind that I invited Adam Weinstein, a member of OCMO in the role of VP of Medical Affairs and Physician IT, to lead today's discussion. We'll be joined by Dr. Stephen Klein from the Detroit area as they discuss the impact of telehealth on care of patients with advanced CKD through home dialysis. These two physicians are actively involved in providing telehealth and are really sensitive to the challenges that many of you may face, as well as providing recommendations as to how we should think about telehealth application as we go forward. The social unrest that has tugged at all phases of society during the last several weeks, and the importance of understanding, listening, and learning. Wherever we look, this is critical in shaping who we are as individuals and as professionals. I think Nelson Mandela summed it up best when he said, education is the most powerful weapon which we use to change the world. Adam and I really believe this, and we believe these educational series an opportunity really to expand your knowledge and to improve your performance really as physicians and provide superior outcomes to your patients. Thank you and Steve for advancing our understanding and knowledge how you see telehealth and how it is changing your medical world. Remember that all of you are muted upon entry, and I'll instruct all of you to unmute your cell phones when the Q&A portion of today's discussion occurs. So with that, I'm super pleased to present it to Adam Weinstein to moderate tonight's session. Adam, it's all yours.
Thanks, Marty, and good evening, everyone. I'm pleased that you joined us, and I see that we have quite folks joining us from some I know, some I don't, but hope that we can offer some thoughts and discussion points. My goal for the time tonight is to work with Steve and basically have a discussion about how each of us have adopted telehealth strategies for our CKD practice. And as we said, you know, the focus of our efforts is to encourage patients to go to home. And as a result of that, it has caused a shift in how I think many of us practice in the office and have been using telehealth at the pre-dialysis stage as well as within home modalities. And so Steve and I are both practicing nephrology. A little bit about that in a second. Obviously, I'm part-time since I do much more work for DaVita these days, and Steve is a full-time nephrologist. But neither of us have special training in telehealth. I mean, I help run the program for DaVita, which gives me some technical knowledge. But when it comes to actually delivering telehealth, I think what you'll hear from us is that we have worked through a number of issues, as many of you have, and hopefully everyone can walk away with at least one or two good ideas, perhaps thinking differently about some portion of their practice, and walk away with some ideas on how to adapt their practice and their practices to telehealth. So Steve, one, thank you for joining me. Maybe you could just start by introducing yourself, talking a little bit about your practice, what balance of CKD and home patients and in-center, and how telehealth has been, I think, a tool that you've adopted, and talk a bit about where you've been over the the last couple of months in light of the pandemic.
Thanks, Adam. Thanks, Marty, for having me. So I practice in Metro Detroit in Oakland County, a single specialty nephrology practice. We have about 20 providers. We have about, I think, 13 advanced practitioners and over 1,000 dialysis patients. I'm the director of a home unit. We have 2 home units. In my home unit, we have almost 90 patients. And I do about of my work in the interventional field. And then when it comes to the dialysis population, I've been feel like a home champion for a long time, looking up to Marty for a long time, and really trying to use this opportunity as a medical director in a home unit to continue to push that agenda forward. As a whole has 18% prevalence on home dialysis patients, so I'm proud of that, but I think there's a lot of work to do and a lot more that we can accomplish. I will a little bit of telehealth before this started, and I have one home dialysis patient, a patient who lives about 90 minutes away. And months ago, the DaVita staff came to me and said, "Hey, would you like to use this Care Connect thing?" Care Connect was, so I said, "Sure." I'm usually a pretty participant, so meeting this patient, doing one telehealth visit a month. And on that, I had no telehealth experience in the dialysis population and no telehealth experience in the CKD population. So that's where I started from. And the past few months, it's been a learning curve and a very rapid progression in adopting telehealth. Utilizing telehealth in the office as well as the dialysis clinics. I haven't figured out how to use telehealth in the interventional suite yet, but yeah, but who knows? There's been a lot of changes with CMS. So now we're seeing almost all of our patients, at least our home patients, via telehealth. But we're a lot of face-to-face visits with ESRD, the in-center patients, just keeping appropriate distancing. So.
One of the things that I know a number of us had to do was rapidly alter our workflows. And so in the months leading up to COVID, I've been playing with DaVita Care Connect, and I saw a few of our PD patients instantly, but I found myself using it like you did for geographic gaps. I'm in a rural community, and there's patients who are at a distance, but I really found that it was most valuable for visits between visits. So if I had patients that I was hearing about trouble, something you could potentially schedule some time to see them between your monthly visits in person. But I agree with you, it's been a rapid learning curve. And one of the things I've noticed is that the shift, especially to office-based health, CKD care, oftentimes resulted in the punting of activities that, in my mind, were more routine in face-to-face visits. Have you found that to be the case in your practice as well, where you're putting things off, saying, well, COVID will be over in a few months and maybe we'll be back to the office? Have you found yourself delaying what would otherwise be appropriate care or, I guess, typical care patterns for especially advanced CKD patients?
Yeah, it has been. It's been a real challenge. We have been working in the last few years on trying to develop a more comprehensive C program. As part of the KCF application and CKCC application, we were also working on trying to develop a program that could support caring advanced stage patients. So I had some mechanisms in place already that I could rely upon. For example, if I needed to have dialysis education and I didn't have time to do it, I could ask my advanced practitioner to perform the dialysis education. But your point is well taken. There are a lot of things that get pushed back that become less urgent when you have the resources or the time to deal with them. So you end up focusing really on the things that are more critical. So there definitely has been a period of, I think, punting some of the things that can be punted.
I found a couple trade-offs, like, less lab work, especially early on, and when I think it was a bit more chaotic. Though my local labs have done a pretty good job in terms of keeping patients safe and scheduling things and leaving people in the car until it's time for their appointment. But early on, we were missing labs for the CKD patients as well. What is your office workflow with your office-based CKD? Do you have your staff contact the patient, prep them for either the telehealth appointment or the phone call, do some pre-work, and then you call them, or is it much more of a seamless process based on your technology?
Yes, what we started doing was first calling the patients to see if they had even done their labs. Patients had not performed labs and they had no concern and they weren't, recently hospitalized. We decided at that point to delay their visit. For patients who had labs done and who were comfortable doing a telehealth visit, we would schedule them to virtual visit either by audio only or by audio and video if possible. And we would ask them questions ahead of time. What kind of phone they used, and if they had email, and if they had a camera on their computer. And we did the best we could to try and troubleshoot some of that stuff ahead of time. Invariably, we still ran into a lot of challenges. We tried to learn some of the way that we interacted with patients based upon the technology that they had available, or at least maybe have a backup plan in place. Because there are certainly some non-HIPAA compliant ways of interacting with patients like FaceTime that are very, very easy. But I still preferred to try to use those applications that were HIPAA compliant, that had more work on the front end. So staff would call the patients beforehand, make sure that they had the labs done, make sure they were comfortable with a telehealth visit. And we try to strategize from there about what kind of platform we're going to use to try and connect with the patient and what's our backup going to be.
Got it. Yeah, and it's interesting because even with all of that prep, because we do almost exactly the same thing, which is a lot of upfront work, there's an enormous amount of missing data that I perceive. And so, I don't know what percentage of your patients are able to complete a full audio and video call. We're probably 60-70%, which is say high, and it varies, obviously by patient and their capacity. But just, missing vital signs, the number of patients able to successfully measure blood pressure or pulse at home, they even have a cuff is an inaccurate reading. I'd say that the medicine list gets a bit more accurate because they can actually either show it to you or they have the ability to look at it while they're talking to you. And then I think, there are other data missing. Obviously, physical exam data, there's certainly things I would observe when entering the room or things about watching the patient enter come in from the hallway if I happen to be present as they were being brought back to the room. A whole series of data elements that are missing. I don't know if you've observed a similar kind of thing and maybe thinking about how you fill in those gaps and whether other aspects of the physical exam and I should say the interview process have become more prominent.
You're right. Some of the components of interacting with the patients, just by virtue of the fact that you can't be in front of them, they have become more important only because they're probably more available. Physical exam is obviously crucial, but it's really difficult to perform. And I saw a new patient yesterday for hyponatremia who had ascites, and I asked them, can I see your belly? And so they're holding the camera 3 in their belly, and I'm asking them, can you move it farther away? And they're trying to hold it off to the side. And I just thought to myself, my goodness, it wasn't great. I had the same experience with trying to look at patients' edema, and I feel like it's a really simple request and being frustrating for both of us. So I try to focus on things like, is the patient in distress? Is their breathing labored at all? I ask them, how their abdomen feels, if they're having any pain, ask them about their swelling. But it does become a cursory physical exam. And then you're right, medications probably are a little more accurate because patients are at home with their medications. Fortunately, for my company, we did transition to an Epic-based EHR in February, so it's given me a little better access to other doctors' medical records, which helps in just coordinating care. So I've been able to fill some history gaps there, but it's been a challenge. It's been an interesting learning experience.
So things I've experienced is that I've actually when it first started, I noticed that spouses or other loved ones would join in the call in a way that was also unique. So not even remotely, they would be home with my patient. And the joke I had with the patient is, is your attorney in the room with you when I heard the voice from off screen? And of course, they would laugh and I would laugh. But what I found is that not only can spouse participate in the data gathering as you would expect if they came to the office, but they can hold the camera and they can do things that help the patient manipulate a more robust physical exam. And certainly with my PD patients that I do telehealth visits with, if you want to examine the exit site, the only way I've been able to successfully do that is when a third party holds the camera for the patient. I don't know if you've experienced that at all or had any engagement with other members of the family while you're on the call with the patient.
Yeah, I think one of the things that's really great about this experience is anytime we have challenges like this, right, it's easy to get frustrated and check out or just kind of gnash your teeth. But you have to look at challenges as opportunities. And when doing a telehealth visit with a patient, I'm seeing the inside of the patient's home for the first time. I'm seeing maybe grandkids. I'm seeing chaos, or I'm seeing peace and calm. So I think there are some opportunities for us to maybe have a little bit different look at what's happening in the patient's life. And you're absolutely right. There's fan involvement that we otherwise wouldn't see. And for our male patients who come in and say, oh, I'm doing fine, Dr. Klein, I'll see you next time. We have a little more spouse participation, and I think that's been great. And I think it creates, even though it's virtual and even though there's it's a little bit personal, it does create a connectivity when you're able to see the patient's family. And let's face it, our world is connected on clicks and video apps, and people are becoming increasingly familiar with groceries and ordering. I mean, even I had a family member order an automobile last year online. So this is how the world works, and even though it's a little bit unusual in medicine, I think there's some opportunities that we can take advantage of.
My favorite story from telehealth is I was doing an appointment with one of my patients, and as usual, he's an advanced CKD patient, and he was going through various things that were going on. He's a diastolic heart failure and slowly losing renal function over time, and he's telling me all about how good his diet is. Sure enough, as he moves the camera around, there's a big holiday popcorn tin right next to the chair he's sitting in. And I totally called him out on it, and it was so fulfilling to be like, look, you're lying to me totally, and and it started a whole different conversation. And I've not yet said get up and go to your pantry and show me what's in there, but certainly that's on my list of now things to do based on that experience, which is another, I think, opportunity. And while I, as the doctor, don't think that that's a great use of my time necessarily, I can certainly see a role for my office staff who may be engaging in CKD education to thoroughly look at the pantry with the patient over telehealth. And certainly I've had my PD dietitian go through what's in the patient's fridge as a means of phosphorus control. So I think you're right. Looking for those opportunities is a great way to go. The other piece that I've learned is a number of my patients, especially my older patients, will typically have me speak with the family members. And telehealth provides a multi-person, real-time session that is more robust than anything we've had. And so one of my patients has daughters in multiple states, and we bring them all in for the appointments now because it's possible. In the office setting, you might get one on the phone as a speakerphone if one is not available locally, and all of those things. I don't know if you've experienced any of that as well, but I found those to be important opportunities to embrace, I guess.
Most of the time when I'm seeing patients and I'm done with our interaction, I will message my staff because they're obviously not with me. I try to do my visits not at the office because I'm close to COVID and the hospital, and Michigan has been a bit of a hotbed. So I will message my staff immediately through the EHR and say, hey, this is what I wrapped up with the patient, and this is what I decided, and this is what I'd like you to contact the patient about. But even after you do that, there's still some confusion, right? Sometimes the patients don't understand exactly what it is that I want. So I use various modalities, depending upon which technology I'm connecting with the patient. And I add my staff to the phone call. And there I've got the patient, and I've got my staff, and they're both on the screen with me, and they see each other. And it's a little bit clunky at times, but it creates some connectivity. The staff is familiar with the patient. The patients, I think, feel some comfort in actually seeing the staff. So whatever you need to do to break barriers that get in the way of effective communication, I think as long as you're flexible and you can be creative, you can fill out those gaps.
No, the other thing I've found is that it's allowed me to have more frequent visits, and so especially with some of my advanced CKD patients, and in keeping the ongoing conversation, where you may want to see someone every 10 to 14 days or even 7 days, and someone with a very diminished GFR who's approaching dialysis but perhaps not quite ready. I have found that the frequency of visits that you can afford, or you can, I guess, engage in with telehealth is a lot easier, since there's the not dealing with logistics of travel. Have you changed the frequency visits for your CKD patients at all, or thought differently about how often you see them, because they don't have to leave their house now, or are you keeping to the traditional, cadences of care?
Yeah, so that's a really great question. Because we're trying to sort of create a program that we can use for something like our KCF application. We do have protocols in place about the frequency of visit to see the patients, and I mostly adhere to that. But if there's a patient that needs to be seen, the platform does allow us flexibility. But if patients don't feel comfortable going out and getting labs, then it's difficult. You want to call them and talk to them about their blood pressure. I mean, that's going to call them, but they may not be even checking their blood pressure at home. So there might be some other things that I want to talk to the patient about, even if they don't have labs. Most of the time, I'm starting off with do you have your labs? If you don't have your labs, you go get your labs. If you don't feel comfortable getting your labs, that's fine. They're advanced CKD and they've got stage 5, and I'm concerned about signs or symptoms of uremia, then I might press them a little bit to go and get the labs done. But otherwise, I kind of start with do you have your labs done? And after that, I've really been seeing them at whatever was already scheduled beforehand, because let's say a lot of us are scheduling our appointments out 6 months, 12 months. So the patients are already on our schedule. I'd be throwing in some patients, who got out of the hospital, or like you said, some patients whose disease has progressed. But I think it allows us just that flexibility. If you're doing some of these telehealth visits, maybe from your office in a non-traditional space like your home, and it affords the opportunity to fit a visit in with, Mr. Smith, AM, because you've got 20 minutes. So I think just being flexible and adapting is kind of how we've tried to approach it.
Yeah, in the lead up to this call, you and I were discussing some of the work that goes into starting one on a home modality versus in-center, and that I see a huge opportunity for the what I call the heavy lift up front of getting people at home, which means when I'm getting people to PD as their primary modality, or as their first modality, I find that it takes a lot more upfront discussion and a lot more time and energy, and sometimes really, weekly visits as they approach the need for the PD catheter. And I've really looked forward to using telehealth for that. And I know that, as I counsel these patients, it becomes just so much easier. And I really hope that in the future we can convince us to let us have some continued use of telehealth in the office setting for that very reason. Just inconvenience of saying, oh my God, this patient is going to need this in the next 6 to 10 weeks. I have to now adjust my schedule to squeeze them in because, as you said, we're all so very booked up and very busy, and it gives a lot more flexibility to add one more patient to the day without them having to drive to see you. And I think that's a huge opportunity as well. I don't know how intense your pre-EKD discussions are or what education you're doing, but have you seen change in those patterns based on the telehealth use?
Yeah, for sure. Because again, you are more accessible. Patients, they miss the fact that they can't see you in person, but they enjoy the fact that when Dr. Klein's running an hour behind, they're in their flower bed. It doesn't really matter. I still try to run on time, but I'm mostly unsuccessful doing that. So no, for sure, it does allow you to change the frequency of your visit if you need to. It does allow for some personal conversations, and granted, it's not face-to-face. The office, you know, the environment that we normally see patients in, I mean, let's face it, it's pretty artificial, right? I always say patients don't really care what your blood pressure is in the office. They care what it is at home. I need you to measure it at home. Well, they might be measuring the blood pressure at home and able to report readings to me consistently, but I'm still seeing them in their home, and that's where they're comfortable. So, and like you said, it does, there often are other family members that are there. So I think it gives us a chance to broaden the conversation and bring other people in and change the visit frequency if we need to. I agree.
You know, I would just put a brief plug in for some of the DaVita resources, since this is the DaVita call, and that we are doing our Kidney Smart education remotely now. So in the event that there are patients that are felt in need of more robust education in stage 3, stage 4, stage 5 CKD, that we have the Kidney Smart team, and it's obviously a local thing to your community who your particular educators are, but they're doing all of that remotely now, and I've taken advantage of that to some degree. The other piece that I found is we have the ability to show slides over a WebEx or over a telehealth visit in many instances. And so if you're not using something like DaVita Care Connect, but rather Zoom or WebEx or something like that in your office, and you can share your screen, there's educational resources that you can walk through with the patient or have staff walk through with the patient. Guys, do you guys in your office use any electronic versions of that, or were you staffed and prepared for more paper-based education for CKD and pre-dialysis education?
We use our advanced practitioners a lot for the dialysis education piece, so we do have some electronic components that have been created, and so they have been meeting with patients in telemedicine format, and they've been able to pivot to do that fairly easily, but I'll have a 40-slide PowerPoint presentation. There are a number of people who are involved in the process, so sometimes it just ends up being a face-to-face. But I wouldn't say that we were prepared. Definitely weren't prepared, but in a situation that's stressful like this, that none of us have done before, you adapt, right? You adapt, you do your best, and I think if you're keeping the patient's keeping the patient's best interest in mind, whatever your adaptation looks like, I think it'll be good. I think it'll be valuable.
Relationship with your community physicians. I've found that actually more time talking to them on the phone since COVID than before, mostly because it just takes a lot more coordinating to get anything done. But I also, it feels like I'm actually a bit more kid rather than just the Epic or fax or whatever communication tree that typically happens. My frequency of phone calls and texts with my colleagues is gone. I don't know. Have you experienced any of that, and how have you adapted around the various issues with regards to non-elective surgeries minimizing elective surgeries and things like that?
Yeah, there have been conversations that have been spurred forward as a result of this. I had a surgeon call me a few weeks into the pandemic, and they called me on a Sunday, and they said, hey, Stephen, I have this patient of yours I'm going to see tomorrow for a PD catheter, and it's the pandemic. Like, I'll do it, but are you sure that we want it done? And that was a conversation where I could say, we absolutely want to keep these patients at home, and we don't want to keep them out of the house, where there'll be even higher risks. So yeah, I want it done. And I understand there's a risk in taking it to the hospital and the surgical center doing the procedure. But I think the risk is better than having crash into the hospital and end up with a catheter and end up in the in-center unit. So collaboration has changed, right? The phone calls I might have with the surgeon in that example, or the time spent in the hospital where I'm there every other week with physicians, wearing the mask 12 hours a day, and just the camaraderie that you kind of develop when you're going through a stressful time and everybody's trying to do it together. I think both of those change the way that we interact with our colleagues. So, yeah, maybe there's been more text messaging. There's been a few more phone calls, been some more shoulder-to-shoulder time where you're both or you're all just trying to do your best in a really difficult situation, figuring out how to put, the PPEs on in every patient. So you're right. There's been a action of communication.
Address the risk with the patients. I pointed out there's a whole series of patients where they won't even get their labs drawn. They're rightfully afraid, especially if they have some comorbid conditions that put them at higher risk for a more severe case of COVID and where they could get infected. How have you described that risk to them in the hospital setting? How have you I guess, overcome whatever fears or doubts for the ones that absolutely need to go have something done, whether it's PD catheter placement or even just interventional stuff in your interventional clinic?
So when it comes to the office visits, in the hospital, the conversation is a little bit different because the patients are on the floor above them or the floor below them. So I don't typically have that kind of conversation with a hospitalized patient, but with a home patient or with a CKD patient, there are things I try to focus on. When we give patients a lot of information, just like when we receive a lot of information, it's really difficult to distill that down into something actionable. So I leave them with just maybe one or two things. And I ask the patients with regard to COVID, I say, are you socially isolating yourself, which has been really important in Michigan. I ask them if they are getting their groceries delivered or if they have family members that can bring them to them. If no, are you wearing masks and washing your hands? I try to explain to them that they're, they need to think about not just wearing masks and having other people, cough or sneeze in their direction, but they also worry a lot about washing hands and just practicing that kind of safety. So my conversation around that kind of stuff really focuses on social isolation, and then if you have to be out in the community, appropriate distancing and hand washing. And those are messages that in the state of Michigan we've gotten pretty consistently. And most patients that I talk to, and my practice is kind of split up in a couple different areas. So I have homogeneous areas that are a little bit separate by about 20 miles. And so the patient tends to be a little bit different. But in a lot of areas, I'm able to say, can you deliver your groceries? Can your family members come and leave stuff at the porch or leave your medications? Get your medications for 90 days so you don't have to worry about going back to the pharmacy. And so those are the things that I try to focus on, the patients with regard to COVID. And then I've also actually had some really interesting conversations with patients about their emotional health because, let's face it, isolation is difficult. And some patients who've lost a spouse or live alone, this is a really difficult time. So try to be empathetic and tell patients, look, it is difficult. What you're feeling is normal. Being isolated is challenging, and you're not alone. And try to be an encouragement to them. Those are some things that we have an opportunity to do now that we're visiting our patients in a different way.
Those are really great points. We're going to finish up with I think our discussion open to questions in just a second. But let me ask you this. It sounds like from your comments that you feel like you could see telehealth becoming a permanent part of your practice. Is that something you would welcome if given the opportunity to do this, especially for the CKD and into the home and do you see yourself utilizing it more based on your experience during the last few months?
Well, that's great. I have concerns about telehealth. Concerns are based on how, as a physician, it potentially changed the way that I am viewed by CMS and by insurance companies and my value. I interact with everybody by telehealth. That client isn't needed. I don't know if those kinds of thoughts or fears are unfounded, but those things that I ponder. So I don't think that I'm at a point where I say, telehealth, I'm ready. Let's just do telehealth. And you lose human connection. But as a human, I'm also a creature of habit, so it'd be really easy to, when the global pandemic ends in months or a couple of years or whatever, it's really easy just to say, I'm just going to go back to the way that I did things before. It would be a mistake. I think that for us, whether we're talking about our own personal lives or whether the way that we interact with patients, I think that we have an opportunity to look at what are the challenges that I faced, how did I overcome those, and what is it that I want to take away from that I can adopt into my practice. And I think telehealth has a role. I do. I think that, for some patients who are able, who are doing well, who haven't been hospitalized, I think it's reasonable to use some telehealth visits exclusively, but to use some telehealth visits to interact with them. I mean, there's difficulty getting out of the home. There's patients that have difficulty with transportation. In one of the communities I practice in Pontiac, there's patients who are taking the bus, patients who are walking to clinic. So this is an opportunity to, I think, offer service that's more convenient, that's a little more 20/20 for patients. I think it's also important that we don't lose that connection with patients and that we do continue to see them in the office. So I'm not sure what that hybrid blend is going to look like down the road, but I don't think that the telehealth is just going to go away.
There's a lot of discussion within the various nephrology organizations about this as well. So I think your thoughts are spot on in terms of where everybody is at the moment. So again, I don't know how we want to handle the questions, but I think Steve would love to hear what's on other people's minds. They've probably heard plenty of us chit-chatting for now. It really can be anything from some technical considerations of telehealth to other observations. If you want to call us out because we are completely missing the boat in some way, I think we'd certainly be open for that discussion as well. But I would like to hear what's on your guys' minds and what kind of things you've experienced and whether there's other valuable points that are worthy of mention.
Adam, thanks. So if you're dialed in via the WebEx platform, you can simply click the red microphone icon next to your name to unmute yourself and ask a question. Or if you're dialed in just via the phone, you can press *6 to mute your line and ask your question. You can also chat in your question via the chat box. So a couple options there for you to get your questions answered.
In the space where we're waiting for set questions, I will give I think the pitch about what it is we're doing at DaVita so you understand the telehealth tools you have at your disposal. At the moment, we do not offer a CKD or a clinic-based telehealth solution. Some of the practices that are Epic using practices on behalf or with DaVita, our NCA-affiliated practices are using Mend, which is a company that we have worked with and certainly have, I think, brokered the relationship with. We own or take a financial stake in. We do, on the other hand, offer DaVita Care Connect for our home-based modalities, and for the team, we're using WebEx, the in-center telehealth tool. All three of those, and many offices are using their own choice in the office setting. All three of those are really currently required, which is not ideal, but that's how we were able to ramp up quickly. And I envision a future where we'll be consolidating in time, especially toward the end of the year as the waivers start to diminish. So I see our first question from Michelle. It says, how many visits in a row do you feel are reasonable to leverage telehealth with able patient if there are no CMS restrictions post-waiver? Well, I'll give my answer on that. And Michelle, if you could just clarify it, because I think there is a difference for CKD versus hemo patients versus PD patients. Maybe the answer would be to give you all three. Active PD patients, says Michelle. So for PD, I would feel comfortable. Currently the regulations say that you have to have one in-person visit every quarter, and then that's currently waived based on the waivers. And that felt about right. I could probably do a few more if the patient is super stable. But in general, I feel the maximum I would want is at least seeing the patient 3 or 4 times a year, which gets you to the same number. Now, whether it would be the same cadence, whether it would be is debatable. but really is of value to touching and looking and seeing what the patient's demeanor is like, and doing that in a group setting where the social worker, the dietitian, and the nurse can all interact with the patient with me in the PD clinic. Steve, I don't know how you feel about that. What's your comfort number if you have such a thing?
When my only experience with telehealth prior to this was in the PD setting, so I was seeing my patients once a quarter. I had no experience doing it in the office, so I think great question. I don't know the answer to that. I think that if the patient is CKD 3A and they don't have any albuminuria and they're stable, we're already only seeing that patient once, maybe twice a year. So I'm not sure. I think that that's going to be something that's going to evolve over time. I feel like our least stable population is probably the dialysis population, or maybe the patients who are CKD 5 right before they're starting dialysis. And so whatever that number ends up being, I would see those patients more often in person if I could. You know, you're also going to have the patients who just economically are less stable, emotionally are less stable, and those would be patients you might want to see more often. So previously in the home unit, I was seeing patients once a quarter. In the CKD clinic, but who are CKD 4 and 5, probably would want to see them in person more than once a quarter because we're trying to make some pretty critical decisions, and I want to actually be face-to-face with them when we have those conversations. Patients who are CKD 3A, 3B, patients who are CKD 1 or 2 with stones, and maybe seeing them less often, maybe seeing them once a year in person, once a year on the phone, and via telemedicine. Maybe that's a blend.
Yeah.
Good question.
There's two questions I'm going to combine, which is what is the biggest challenges you've faced, and how many telehealth visits do you schedule in a day? And I think I can combine those because the answer to the second one is I think reflected in the first one. Right now we've tried to book telehealth visits for every 20 to 30 minutes for the CKD clinic, and I do 30-minute telehealth appointments for the PD clinic. And the reason I do that is because the biggest challenge we have is the technology. Even though the programs are pretty robust, there are certainly times when the patient has unexpected internet drops or some other technical challenge arises that slows you down. I do find that the telehealth appointments carry a certain so when people bother to show up in my office, at least personally, I feel like you have to put on a little bit of a dog and pony show. They have bothered to come to see you. Therefore, you make sure you cover all your bases, and there's a little more of an interaction. I find I can be far more efficient, especially if I'm more frequently seeing a patient via telehealth. And so the visit itself might be shorter, but dealing with the technical side of it has an overhead to that is, I think, that we have to account for. And so the pre-work, which the office, notifies the patient, preps them for the call, test equipment with them if they can, and then expect the phone call at some point at like 5 to 10 minutes later is how we've set it up. Steve, are you experiencing anything similar, and what are your numbers in terms of the number in a given day, and then, of course, the hurdles that you've experienced?
Your comments are fantastic there. I mean, that's exactly been my experience. My follow-up visits right now are 20 minutes scheduled by my staff. God bless them. I'm never finishing in 20 minutes. Now, the actual interaction with the patient might be 10 minutes, but technical aspects of it can stretch that out into 30 or 40 minutes. I mean, I've been doing telehealth now for 3 months, and just today I saw a new patient in the office, and we had a total of 30 seconds of video connectivity, and the rest of it was just audio only because they had internet issues. So, it's been an ongoing challenge. I think if you can be patient and persistent, then you can overcome those challenges. And I'll give you a couple of examples. There's a lot of ways you can connect with patients, right? In a telemedicine fashion, you can connect with them that doesn't matter, a bunch of different ways. And DaVita has some really slick ways. But I have patients, and especially the dialysis clinic, who, for what reason, they struggle with technology. So I've had instances where I have been using one modality to interact with the dialysis staff. Again, I'm doing this remotely. And then the dialysis staff is interacting with the patient in video in a fashion. So we have 4 different devices where the patient is connecting to the staff via WhatsApp, and I'm connecting to the staff via, FaceTime. And then 2 forward-facing cameras, and I can see the patient in a picture in a picture. That is so ideal. Still doing it, right? I'm still being creative, and that's not the way that I prefer to do it. But that's the way that it ends up being. And you're not going to look for perfection. If you're looking for perfection, you're going to fail. So you can just find what's going to work best, going to work for the patient. You're going to have success.
Yeah. So Marty asked an interesting question, which says, because access procedures have been a big hurdle, what are your thoughts on using predictive analytics and formulas for risk scores like Tangri? So, I think I have a broader thought than just a risk score per se, which is, as we have punted work, there seems to be that we are going to hit a point where we need to go back through the schedule to who was punted, who was dropped, and then sure those people are followed up with. And so I think Marty's bigger point the bigger point I would take away from Marty's comment is that if you're not doing population health within your practice, you're going to have to do something around population health or something that approximates it as this winds down, as you get back to the office. And so one of the things that I've done is we're reopening some face-to-face time in our CKD office. And in my rural community, we have a subset of patients who don't have internet access or anything but a telephone in their house. And so we're bringing those patients back in, especially the advanced CKD ones, which means we had to comb through our schedule, figure out who was canceled. It's been quite an endeavor because those are not routine reports run in this way or use them in this way. Steve, have you experienced any of that at all?
Marty, that's a fantastic point. So, initially when this started, you're just trying to get your bearings, and you're just trying to figure out how can I even see patients. And it's clunky, and it was difficult. And now we've reached a point, a couple of months later, 3 months later, where we're saying, wait a minute, more strategic. We need to really focus on CKD 4 or 5 patients because let's say they didn't get their labs, or let's say that they kind of fell through the cracks, they canceled their appointment. We have to be persistent with those patients because they're at high risk. So initially we were reactive, and initially we were just trying to figure out how to even accomplish a successful visit. And we're stepping back and saying, okay, wait a minute, who should we really be targeting our efforts on? Because we don't know how long this is going to go on. And like you, Adam, we are trying to see patients in office, some face-to-face, to try and reintroduce that and figure out what's a safe way to do that. But we've sort of shifted our attention to a population health approach because there are populations that need to have, a little more attention. And to a point, like even about risk analytics, I mean, for my 4 and 5 patients, I give them the Tangri model every single time, and I type in metrics into the internet, and then I go ahead and print it out, and I hand it to them, and I say, hey, here's your starting dialysis in the next 5 years. Some of that has been, you're usually surprised that their risk is much lower than they thought. And the benefit for me, it allows me to put some reality behind what it is that we're talking about. Because let's face it, kidney disease is abstract. Patients are sick. Again, this has just created a unique opportunity for us to figure out new ways to engage with our patients, and maybe even look at population health in a way that we weren't doing before.
Totally, and thank you. The next 2 questions, and certainly we're coming toward the hour here on this stuff, but I think, so long as there's questions, we're happy to keep talking it within some degree of reason. The next 2 questions I think are actually also related, which is, one, have experienced a hard time with audio when performing telehealth. It seems like all patients have a hard time figuring out how to place their phone or device for us to hear each other. So both for them to project their voice back to the device as well as them to us. And then the second question, Dr. Klein mentioned he easily adapted care for a patient prior to COVID, with many of our provider groups utilizing different platforms for telehealth, either from their office, in-center, home, et cetera. My question is, what challenges did you have learning and becoming comfortable utilizing multiple platforms, and any recommendations to prompt these concerns to hesitant providers? So both of those speak to something that I find critical. I obviously I'm a technology bent person. That's what I'm paid to do by DaVita, is be the tech guy. But beyond that, one of the things I've learned along the way is that you have to play with the stuff to figure out what works. So it's out of an instruction manual. And my wife and children have been victimized by telehealth applications over the last, say, 2 years as I've tested out a bunch of stuff. A number of times I've tested out a particular application where my wife is the recipient of the telehealth appointment, or I'm calling myself on my own cell phone to ensure my camera and audio are working well. It gives me personally the familiarity to do some rough and dirty troubleshooting so that when the patient gets on, we can address things like audio. We can address things like, or the button is on the screen that does whatever it is that it needs doing. And so knowing what the patient is seeing is very, very helpful. Obviously, using software for the office that keeps it simple, so things that don't require patients to download apps, is a more ideal setting. That's obviously not the way DaVita Care Connect is today, but certainly a way we would like to evolve it in the future. For the moment, DaVita Care Connect is a downloaded app, and certainly we've been offering our patients guidance on how to do that within either the office or over the phone in prep. But in my mind, there's no perfect answer to this, because tutorials and all that only get you so far. I really have, multiple devices. I'm sure many of us have iPads and laptops and iPhones, and engaging my family as the guinea pigs for these kind of activities. So I don't know if you have any thoughts on those two things, learning and then troubleshooting on the fly, which I never thought I would be giving out technical advice like I did to my parents, to my patients, but certainly that seems to be a thing now.
Yeah, I do. So I just quickly made a list. So here are the ways in which I have interacted with patients. Other than just calling them on the phone, right? I've used Microsoft Teams. I've used DaVita Care Connect. I've used Bluestream Health. I've used Doximity. I've used FaceTime, WhatsApp, and Zoom. Have the ones that I try to use most consistently, just based on its ease for the patient and ease for me. Adam said, if they're downloading an app, and at least in my elderly population, forget it. Unless their children are going to come over and help them, it's going to be a challenge. So I really need it to be something that completely intuitive, requires nothing from them other than to even touch a link. But, oh my gosh, I'm sure we can all share stories about trying patients to touch on a link, not knowing that their phone has a camera. I mean, they're, like I said, every clinic is interesting. If there's a patient that I run into where I've challenged and I can't connect with them, I'll text my staff through my computer and say, hey, I'm having trouble connecting with John. Can you figure that out, troubleshoot that? I'll move on to the next patient. I have used a lot of these platforms with my staff, just test them out, the ones that were unfamiliar that I hadn't used before, because I want them to understand what the patients are seeing. And then we do it, they use it on me as well, so I can understand what the patients are seeing. And that just helps us be more effective communicators when we're calling them on the phone trying to troubleshoot. So I think, having a couple of platforms that you really like or that you're comfortable with that doesn't require much from the patient in the office is helpful. I have sort of my go-to that I try to use first. And if, it doesn't work, it's the other one. And sometimes it works better with the other one because maybe they connect via email better. Or their phone didn't have a camera. When it comes to the dialysis unit, at the PRS units or the DaVita units that we go to, the teams mostly have been really motivated and very helpful to try to connect. And I end up using whatever technology they would like to use that their LDO wants them to use. So in those ways, I've adapted because I've used some of those technologies previously. So flexibility is key.
Yeah. Well, so I think we'll close there unless there's any other super pressing questions. But I just point out now that, Steve, we nephrologists get to do like cardiology, medication management, dietary advice, food shopping advice, all sorts of social work related issues, and now technology advice, which is just yet one more thing in our sort of panel of expertise. So fixing your patient's iPhone. I will also say, what's that?
I'm a nephrologist. I mean,
right. And acid-base equations. Well, Marty, why don't I turn it back over to you to wrap us up for the 9 people of our talks. And thank you, guys, and thanks, everyone, for listening. This was fun.
Thank you, and Steve, thank you. I mean, great critical information that I'm sure the audience will walk away more knowledgeable than they were before session. And it's amazing because we know the world is changing. We know that the traditional approach that we have conducted for care of patients is changing. And telehealth is going to be balanced, doing a telehealth visit and seeing a patient face-to-face. And it's really, I think of telehealth as helping me triage patients. So keeping patients safe, however, they need to be seen face-to-face, then telehealth really is an approach that allows me to do it. And I think it's important to stay connected with your patients, ensure that your team are staying connected with the patients, but I really appreciate all the awesome information. I just want to remind the audience regarding the upcoming webinar session that will be taking place. And so on June the 24th, we really are going to dig into those that present to in the center program, either crashing into the center or prevalent patients that we look upon home as a place where they want to care for their kidney disease. And how do we empower them? How do we enable them? And how to educate patients? So I think that's going to be an informative session led by Mark Shapiro on 6/24. And then on 7/8, we really are going to discuss the urgent start patients or the crashers. You know, how do we access place in those individuals? What are some issues regarding getting a patient with PD catheter in a hospital and transitioning them to the outpatient area? And subsequent to that, we'll have case discussions about home dialysis, about the home-to-home transition. We're going to have case samples of peritoneal dialysis, you know, issues that come up in your peritoneal practice. And then, you know, on the 19th, we really are going to focus with Leslie Wong and Brad Wardy to discuss from a nephrologist transforming dialysis safety, or the NTDS initiative of the ASN. We think about driving infections to zero in dialysis, just like we're doing in in-center dialysis. So a number of, I think, awesome topics that are going to be presented every other week. So I encourage all of you to really stay, to have those topics on your calendars and to tune in at that time for a very lively and interactive discussion. I really thank all of you tonight for taking the time out of your lives really to listen and to learn. Again, the constant phenomenon, but it makes us better. And as such, we're going to be better physicians for our patients. And I'll conclude tonight's session, but I really want to thank both the speakers as well as the audience for participating.
Thank you for joining tonight, and you may now disconnect.